everyone, in today's video, we are going to be exploring medications used to treat schizophrenia and their side effects with pharmacist Matthew Elswood, who I'm so excited to introduce you to. Matthew is a pharmacist in the UK who has been working as such for about 20 years now. He currently works for Nottinghamshire Healthcare, and he also advises the NHS on mental health pharmacy issues. Matthew has so much expertise, and I'm so excited to hear more from him in this video about medications and their common side effects. I just want to take a minute to remind you about our online peer support community. It is a really wonderful online community filled with people who have shared experiences of navigating a schizophrenia spectrum illness and their support people in their life. It is a wonderful way to connect with other people who may be experiencing similar things as you, and we offer peer support through various text channels as well as weekly peer support groups. So if that is something that interests you, or if you just want to help support us in creating content like this video today, please make sure to check out the link to our Patreon page, through which you will gain access to the online peer support community once you become a patron. Okay, so without further ado, let's hear more from Matthew. All right, so hello, Matt. Thank you so much for joining us here on the channel today to talk about medications used to treat schizophrenia and their side effects. We're so excited to hear from you.
Great. I'm really happy to be here.
Yeah, so I guess just to dive right in, can you tell us a little bit about the classes of medication that are commonly used to treat schizophrenia, and then just kind of briefly how they work to affect your brain and improve symptoms?
Sure. So here we're really talking about antipsychotic medicines. Despite lots of efforts to introduce new and different types of therapies over the years, antipsychotic medicines remain the mainstay of treatment of schizophrenia and psychosis, I would say. And in terms of different classes, there's different ways that you can break them down. So there's a way of looking at antipsychotics depending on which receptors they work at and which side effects they most likely have. So some of the very first antipsychotics are potent dopamine blockers in certain dopamine receptors in the brain. And the theory is that that's what reduces the symptoms of psychosis. The most common side effects that people would have with those potent dopamine blockers is movement problems, problems with some hormones. And I know that we're going to come on to talk about side effects a little later, so I won't go into more detail on that now. So those were called conventional antipsychotics or first generation antipsychotics. And over time, what we learned is that if we blocked serotonin receptors as well as dopamine receptors, that some of those side effects would be less and the medicines would still work. So a new class of antipsychotic medicines called second generation or atypical antipsychotics came into being. And those are probably the most commonly used treatments today. So that's one way of looking at antipsychotics. Another way is to break them down practically into oral medications, so things that you take as tablets or as liquids or capsules, and injectable antipsychotics. So you might have a depot injection every 2 weeks, every month, or maybe even these days every 3 or 6 months with some of the most modern injections that have become available. So those are the ways that I would choose to categorize different antipsychotics and how they work. It's really about these dopamine receptors and these serotonin receptors in the brain, or at least that's what we think. Although our knowledge and understanding of how medicines work is constantly evolving. And I'm sure you'll have seen recently all of the articles about depression and serotonin, and is it really important? So we constantly learn about the science of the brain, and we have to remain humble as a consequence.
Right. Well, thank you for sharing where things are currently at. That's helpful. So a question that we commonly get asked on the channel is what medications I personally use. And we don't answer that because it's known that medications affect everyone differently. And I'm just wondering if you can tell us a bit about why that is. Why do they work differently from person to person?
Yeah, sure. And that's a really interesting and challenging question, because I don't think that there's a clear answer, or I'm going to try to give you an answer as I see it. So I think it's fair to say that schizophrenia and psychosis are more like a family of conditions, not one single condition. And why do I say that? Well, the way that people come to have that diagnosis differs from person to person. So some people might have it in their family. So there's a genetic component, albeit that's not straightforward. There may be 200 different genes involved. Some people might get the condition because of use of substances and things like cannabis and amphetamines and other things. Some people would have had a very difficult childhood on their way to receiving the diagnosis of that condition. And some people will have trauma in their lives. So there's lots of different ways that people arrive at having schizophrenia and psychosis. But also, from working with people over the years, what I found is that no two people with schizophrenia are quite the same. So people will experience voices and various types of hallucinations. Some people will become very paranoid or worried about other people and their intentions. Some people experience something called catatonia, so they get very stuck and they can't seem to get moving. So the way that people experience the condition, no two people are kind of the same. Everyone is different. But also to add to that, personality-wise and in health terms, all of the people I work with are very different. They have different health problems. They're different people in terms of who they are, their personality. They take different medicines for their other health conditions. And so then it makes sense with all of these different factors that each individual will respond likely differently to different medicines. So I think it's fair to say that we need to treat people as individuals and try and find the right treatment for them, taking into consideration what they're hoping to achieve, the particular type of condition that they experience, their medication and other health concerns. So it's really about working with individuals. Does that make sense?
It does. I suppose I'm still kind of wondering in terms of, treating a specific heart condition. Generally speaking, the same medication will work across the board, even though that people are different and people have different health concerns and whatnot. So, it makes sense to me that we would treat it from an individualized perspective in terms of having all these different factors. But then it doesn't make sense to me in terms of looking at other health concerns and how we treat those.
Yeah, and that's where it starts to get difficult to go much further with the explanation. I think there's a very simple way we could choose to look at this, and that is that we probably know far more about the heart or the lungs, albeit we're learning all of the time. We probably know far more about other organ systems and other conditions than we do about the brain.
Right.
And the brain is incredibly complicated, and we're still learning so much about it every day. And what I would say in terms of thinking about healthcare, the kind of very simple way I tend to look at it is we're trying to achieve something, and it's about knowing which levers can we pull with which medicines that we've got to try and achieve the selected end result. And it might just be that we don't know which levers to pull quite yet for schizophrenia and psychosis, and there might be a whole bunch more levers that we're yet to discover that might open up new approaches to the treatment of the condition.
Right.
So over time, we might get much better at treating this condition.
Well, I would love to ask you more about the future of treatment, but we'll save that for the next video. So can you tell me a little bit more about what some of the common side effects of these antipsychotics are? Maybe more so the second generation, as they're commonly more used right now.
Yeah, sure. Okay. So I'm going to touch on all of the major kind of types of side effects that people experience, and feel free to ask me for a bit of information if you want to go into any of those in more detail. So
Sure.
Really common side effects of most antipsychotics include having a dry mouth, maybe having a drop in your blood pressure initially. People can find themselves dizzy and unsteady on their feet. People can be constipated. They can have problems with passing urine. So these are what we call anticholinergic or antimuscarinic side effects. And they're particularly common when someone's starting a medicine or when the dose is increased, because your body over a couple of weeks tends to get used to these problems and tends to rectify it itself. So that's one group of side effects. I mentioned before the movement disorders, and the medicines, the second generation or the atypical medicines have less of these, but that breaks down into four things. So one is called akathisia or restlessness. And it's where someone feels like they can't settle, they can't be still. They feel uncomfortable in their own skin. So that's one type of movement disorder. Another one can be tremor, so having shakes. People can find that their muscles are stiff and they're slower when they're walking. And some of the medicines create this condition, which is a little bit like Parkinsonism. And some people can have these uncontrollable movements of the body or of the face, and particularly the lips and tongue can be affected. And for some people, that's a short-lasting thing. And for some people, then that will stick around and be quite a bugbear for them. But those side effects, those movement side effects, are less common these days, but we still see them. Then we have sedation, which is very common. And the reason for sedation being a really common side effect of antipsychotics is that, amongst other things, antipsychotics, even at quite low doses, are very powerful antihistamines. And you'll be familiar with antihistamines, and your viewers will be familiar with antihistamines as a treatment for allergies. Many of the antipsychotics we use are very powerful antihistamines, centrally acting, so in the brain, antihistamines. So they make people very tired and very sleepy. And sometimes that's very low doses like quetiapine, and sometimes it scales with the dose. So clozapine, olanzapine, quetiapine are good examples of very sedative medicines. And then there's the kind of hormonal effects that antipsychotics can have. So I'm going to need to take a moment to explain that. So antipsychotics can affect a hormone in the body called prolactin. They can lead to an increase in the level of prolactin in some people. And if your prolactin level is increased, it will affect your libido, so your interest in sex. If it's increased quite a lot and for quite a long time, it can affect your sexual function. So for women, they might experience that their periods stop or become unreliable. So it's interfering with the normal function of the sexual functioning. For men, they might lose interest and lose the ability to have sex because of this high prolactin. And it's because of what prolactin does to other hormones in the body. So it interferes with estrogen, testosterone. But the good news about high prolactin is it is something that can be quite easily resolved and can be resolved quite quickly. So one of the things that we need to be aware of if we're correcting a high prolactin level is that a person might need to think about their fertility, because they might become fertile again very quickly after their prolactin goes back to normal. So they might need to take precautions with that in mind. I'm sure that people will have talked to you about weight gain.
Yeah, that's a big
weight
one
gain
that comes
being,
up.
a common problem with antipsychotic medicines. And it's not entirely certain why that's the case, but there are probably a number of reasons. So one, these medicines are sedatives. So if you struggle for motivation anyway, because you have psychosis, and we know that for some people psychosis plays havoc with motivation, the desire to get up and go and do things, it's being sedated is only going to make that harder for someone. And we know that these medicines interfere in some complex way with our appetite, what we want to eat, and how we metabolize as well. But also, there's some really old studies, if I go really back into the depths of my knowledge here, that demonstrated that people with schizophrenia actually have a slightly slower metabolism than other people in the general population. So there's an awful lot of things going on with the weight gain. And it's not easy to explain. It's also not easy to remedy. I'm afraid that it's no easier to remedy than it is, in terms of weight gain and obesity in the general population, which, as you probably know, is a really difficult challenge to manage.
Right. So thank you. That was really comprehensive in terms of going over a lot of the side effects. I had one question pop up about the sedation and the antihistamine component. Why is there an antihistamine component to antipsychotic medication?
Yeah, and I think when we talk about how drugs come about, we'll go into that in more detail. But in essence, we design drugs to kind of fit into little receptors and to block enzymes and do certain things in the body. And that's how they work. These are these targets that we're trying to hit to make a drug that works. And the human body is ingenious and it doesn't waste anything. So the receptors for dopamine and serotonin and acetylcholine and histamine are all very, very similar, actually. So it's very hard to design a drug that's very specific and just hits one.
Right.
And quite often, a drug will hit several different receptors because of how similar they are.
Right.
And that's why quite a lot of the medicines we use are not as specific as we might want them to be.
Okay. And then also, you were talking about prolactin levels being easy to regulate. So I guess that leads into my next question. But how do you do that? Do you change the medication, or how do you adjust that?
Yeah, sure. Well, we'll start with more of a general approach to what do we do about side effects. And what I would say is that the first step for me is always to think about if someone has side effects and they're coming to me and these side effects are troubling them and they would like something done about it. Well, the first question is, do we still need to use a medicine? Now, the answer for most people with psychosis will be yes, some kind of ongoing treatment is needed. But could we change the person to another medicine that might not have that same side effect? So that's the first approach. And the next approach might be if we need to stay with the medicine, then is there anything that we can do with the dosage? So could we reduce the dosage slightly and see if the side effects become easier and more tolerable? So those are kind of two good approaches to start with. But really, again, it depends on the individual person, their health problem, the medicine they're taking. So to give you an example, some people have to take a medicine called clozapine or clozapine. And I appreciate that names of medicines can vary from country to country. Often people that have that treatment have tried many different treatments, and clozapine is the only one that's worked for them. So that person, you would probably do other things to manage the side effects and keep them on that medicine if it's really effective for them because other options have failed. Whereas if someone's only tried one treatment, there might be more mileage in trying other treatments to see if we can find one that works, that makes the person feel better, and doesn't cause those problems. But when it comes to what do we do beyond that, it's really about individual problems. It's about individual patients and their scenarios. So shall I give you a couple scenarios, a couple examples?
Sure, please.
Yeah. Great. Okay. So if someone was taking olanzapine 10 milligrams in the morning and 10 milligrams at night, and they were very tired during the daytime and they couldn't do the things that they needed to do, then one simple thing that I might do would be to move the morning dose to the nighttime so the person takes it all at nighttime.
Right.
And that might reduce the sedation the person has during the day. So that's an example. Or if someone takes 400 milligrams of quetiapine in the morning and at night, well, could they take 200 in the morning and 600 at night? So they have more of the sedation at nighttime. So it's about thinking about how you can fit the medication around someone's routine and the things that they need to do. Right. If you're not allowed to change it, if you're not allowed to reduce it, then what can we do? Can we monkey around with the dose? Can we time it so that they have the majority of it at a time where it's going to be less impactful? Right. And with sedation, obviously, it makes sense to take more of that nighttime. And then maybe, it won't interfere too much during the daytime, but it might help with sleep.
Right.
Yeah.
That makes sense. I often describe it as really kind of a balancing act between balancing the medication that is effective for you with side effects. Yep. And it's really about figuring out the right combination and the right, combination that fits for each person. So, I think that people can get really discouraged when medications don't work for them or if there's lots of side effects. And this kind of trial and error process can be a kind of a discouraging one. And so I'm wondering, on average, how many different medications does a person try before they find one that fits well, just to kind of give people an idea of, how long this process can take?
Yeah, so I'm going to try and give you a good answer to, again, another really great and challenging question, and where there isn't a strong answer in the literature and in the studies. But there's a rule of thumb when it comes to trying medicines for psychosis. And roughly speaking, 2/3 of people will respond to the first treatment that they try. that leaves a third of people left. 2/3 of them will respond to the next one, and so on and so on.
Okay.
Only about 1 in 10 people will make their way to the third and fourth treatment. But one thing that can really help here is trying to make wiser choices at the outset, and trying to think about what's going to work for the person when you're making those choices. So what we don't want to do is say, okay, we're going to give everyone olanzapine first, and then we're going to give everyone risperidone, and then everyone's going to have clozapine. What we need to be thinking is, what would be the best choice for this person as an individual? We try that and then kind of learn from that experiment with one person in it, move on to the next one. So trying to make informed choices and make smart choices about which antipsychotics we use. So when I'm helping someone to choose an antipsychotic, I'll ask them about, well, first of all, we'll have a conversation about what are the targets that we're trying to hit. So what do we want to change? So we try and get on the same page about that. And then it will be, well, no, I'm going to give you some information about different types of side effects like I did before. And I'll ask the person to tell me, would sedation bother you? If you gained weight, would that bother you? If you had these movement problems, would that bother you? And I get the person to tell me a little bit about what they think about those different side effect problems. And I get them, I suppose, to express a preference. If they had to choose one of these annoying side effects to have, or which one would they choose to have? But then I'll also think about their routine and what they do. So I'm not going to give a very sedative medicine to a young mum who's got 3 children that she has to get ready and take them to school, because she's not going to be able to do what she needs to do. So that's not a good choice. And if you have someone, and as part of their job, they have to, I don't know, fix watches or deal with very small pieces of equipment or do something very detailed or write, then I probably wouldn't give them a medicine that causes a tremor, because it would interfere with what they need to do. So try and think about side effect preferences, kind of occupation and social function. And I also try to think about other medicines and other health conditions that the person has. So It's about kind of bringing all of that information into one place and saying, okay, I think we've got the short list down to 2. So now, let's see if we can pick from these 2. And one of the things that we're doing in England is we're trying to move forwards with something called shared decision making, which is where instead of you going into a room and kind of telling the person that you've got these problems and they say, oh, here's a prescription for this medicine that will sort it all out, and you send the person away. It's about working together to come up with shared goals, exploring options, and sharing the decision making together. And I think there's actually pretty good evidence that if you work in that shared decision making model, you're actually likely to see the medicines be more effective than otherwise.
Right.
And that might speak to how important the psychology is actually in making a choice and in being involved in decision making.
I think that absolutely makes sense. Just from a personal anecdotal perspective as well, when I feel that I have some autonomy in decisions around my care, it absolutely makes me buy into the care a little bit more. And yeah, I see how that could be helpful. Those are not great choices to be having to make, the ones that you laid out in terms of what side effects to choose. But I think I really love how you've talked about bringing the patient into that and working together to figure out what their goals are and, what their preferences are and whatnot. So I think that's really valuable.
Yeah. And we can't be too Janet and John about this, because we know that sometimes people are just too poorly. For whatever reason, things have gone wrong and they're too poorly to be involved in those processes. So sometimes we have to make decisions. And that's where I think you have to put yourself in the person's shoes and try and think about what you would want if you were in that situation, knowing about their family structure and, what they would normally do in their day-to-day life and their other health problems and other medicines that they take. And you have to try to do the best that you can. And then you have to spend the time afterwards when the person's ready and walk them through that decision, the decisions that you made, and, see if they can live with those decisions or whether they're going to want to go back and revisit that and maybe go for a change.
Right. Like, even coming from that perspective of needing to make decisions for the patient, sometimes it still feels like you're coming at it from a perspective of really prioritizing quality of life for the person in terms of deciding how to treat them and whatnot. And so I appreciate that. I would love if that was the approach that every care professional took. So thank you so much for sharing your perspectives and your experience and your expertise around medications used to treat schizophrenia and side effects and whatnot. I learned a lot just talking to you today. And so thank you so much for being here with us.
You're incredibly welcome.
All right. Well, we will see you in the next video, and take care. Thanks, Matt.
Thanks. Bye.
So thank you so much again to Matthew Elswood for joining us today and sharing his expertise and experience navigating medications used to treat schizophrenia and their common side effects. I know I learned today, more about what's actually going on with the medications that are used to treat schizophrenia and a lot more about some of the side effects. And so I hope that you also learned something from this video and feel better equipped to, have these conversations about symptoms that are still happening or side effects of medications with your doctor. I know that it can be a really discouraging thing, kind of doing this trial and error ordeal with antipsychotic medications, trying to find one that works for you with the least amount of side effects. But I hope some of the insights Matthew provided today have been helpful in navigating that journey and, again, helping you have more to talk about with your doctor in order to find the one that's best for you. So thank you so much again, Matthew, for joining us. And thank you all for watching, and wishing you all and your loved ones good health. We'll see you in the next video. Bye.